So I wanted to welcome everyone. I'm Miriam Cooperman, one of the associate directors for PTBI. I want to welcome everyone who's here for the first time. I hope you enjoy the experience, and also I want to welcome back all the stalwarts that come regularly. It's the last collaboratory of the Obama administration. So, very topically, we're going to be talking about sort of policies and what was going on prior and what we might anticipate in the new administration. And I feel just delighted that we're being led in all this by Claire Brindis. And so Claire is the director of the Institute for Health Policy Studies and has done a lot of really important work in this area, and she'll be leading today's collaboratory. So without further ado, Claire.
Part of the reason why we were excited about having the session today is that this is really a time of tremendous uncertainty. And we have to think about how to use a university-based research, scientific platform to be thinking about what knowledge do we have, how to present that knowledge, how to communicate it with a wide variety of audiences. And we are very happy that this audience is made up of individuals from the community, the practitioner community, as well as other guests who are very interested in the topic. And the issues that we're talking about today are quote unquote local to the US, but I know that in East Africa, our sisters are also concerned with many of the issues around access to care, quality, preterm births, and very happy to see Dill is here. And thank you for all of your leadership. Today, I think a lot about the kaleidoscope of women's health and women's lives. That is that we don't, particularly through the PTBI here, have really defined women not just as the vessels to deliver healthy babies. We have really adopted a life course perspective on the importance of women and recognizing also the contextual factors in their lives, the social factors, the economic factors, the cultural factors that all drive whether they're going to be healthy at different parts of their lives. To us on this panel and to many of you, we know how important reproductive health is to assure a wanted child, but also a life in which women have many options that they can fulfill. So we want to be sure that as we embark on the new era and try to prevent the undoing of all of the decades of hard work that all of you represent in this era. Before I introduce to you our members of the panel, I wanted to spend a little bit of time setting the stage, because I feel that one of the major problems that is occurring now is that there seems to be a lost memory of what life was like before the ACA, or the Accountable Care Act, Affordable Care Act, many ways to approach it, or Obamacare. So we will be saying ACA or Obamacare. And I want to say that we want to be sure that this is, each of us will speak for about 10 or so minutes, and we want to make this as collaboratory in terms of sharing information and sharing insights. This is a time where we're hearing a lot of competing new headlines. You know, we hear Obamacare has failed, or it's been rejected by the American public, or you hear Make America Sick Again, or we need to repair the nation's broken healthcare system, removing Washington from the equation and putting control where it belongs, with patients, their families, and their doctors. That sounds good, but what is really going to be behind that problem solving or decision making? And we've also heard the president-elect say statements like, we will repeal the disaster known as Obamacare and create new health care, all sorts of reforms that work for you and your family. However, I think what's really problematic is to be thinking about how healthcare in our country represents 1/6 of the US economy, including hospitals, doctors, insurance companies, drug companies, various other sectors, all invested in to various degrees. And we need to be thinking about how, when you pull one thread, what are you unraveling? So what was the picture before the ACA came into board? First of all, there was 1 out of 6 Americans living without health insurance. About 45 million Americans lacked insurance. I think that was really an immoral time in our lives and in our country. But not only there were people missing in insurance, there were many people who were underinsured, or many people who would go through what's called churning. They would be in one system, but maybe they lost their jobs, and then they would be without insurance coverage for a while. I also want to highlight that because we're thinking about women's health in the reproductive years, I want to highlight that young adults represented a major group of individuals who had no coverage. 1 out of 6 of young adults have a chronic health condition, and many of them would have no access to health insurance because they would have types of jobs that wouldn't allow them to have coverage. Many of these young people and older people would not leave their jobs because they were worried about not having health insurance coverage in their new positions. You've heard about pre-existing conditions, and that was very frightening to people to be thinking about having a pre-existing condition. But oftentimes you would not realize that even pregnancy would sometimes be labeled as a pre-existing condition. Or there would be lifetime benefit limits that insurance companies would have. Or there would be gender-based insurance ratings, really differentiating what women paid for health insurance versus men. There was no focus really on prevention or population health. And there was also the whole issue of the fact that Medicaid was extremely limited. So if a very low-income woman, would be receiving health care through Medicaid during her pregnancy, by the time she would reach the 6-week postpartum, she no longer would have access to that source of health insurance. And finally, I want to say that the premium costs were going up 30% or so per year long before the ACA. Somehow, I think it's very important that we keep in mind why insurance is so important to people. We know that without insurance, people will seek care far less. They will avoid seeking health care. They will not receive the types of vaccinations or screenings that they need for their health care. So it's really fundamental. It's a fundamental right. So what did the ACA try to do in terms of responding to a variety of these issues? And I could spend the rest of the time just talking about what it did in all of its conceptual thinking and conceptual. But thinking about the DNA of the ACA, I think we need to be thinking about 3 major elements. One was the expansion of the Medicaid access to filling in gaps for very low income populations. Individuals who in the past would have had no access now were living in states where they would have access, and the ACA attempted to put into place that people would be eligible, apart from whether they were parents. Men benefited tremendously from the access to the Medicaid, to a level of 138% of poverty consistently across the country. Previously, if you went to different states, you might have different eligibility of different poverty levels that would allow you to get access to it. But as we know, in 2012, the Supreme Court ruled that the expansion would be a state expansion and a state option. Nevertheless, over 30 states do have Medicaid expansion, and many of them about 16 of them represent Republican governors. So it'll be very interesting to see what happens with the dismantling of the Medicaid program. A second big bucket that was built into the DNA had to do with mandatory coverage for preventive care, for maternity care, for no copayment for FDA-approved contraceptive methods. You'll be hearing a lot more about this as part of the panel. Things like breast pumps, things like annual exams, things like having immunizations. And a third major bucket had to do with subsidies for individuals who are not on Medicaid, but whose incomes would not allow them to gain access to buying health insurance. And the other group had to do with the young adults being able to be up in health coverage up to age 26. I want to make it very clear that there were limitations in the ACA. And one major limitation had to do with the lack of coverage for any immigrant population, especially undocumented populations. And if you're a legal immigrant, you'd have to be here 5 years before you could be eligible for getting some of these benefits. And we also know that there's escalating costs. There are ways of improving the healthcare system. So It's not that we reached nirvana, or the promised land. Clearly, this is a platform for continuation of improving on the disparities that happen in our healthcare system. So very quickly, I just want to highlight a few things of what happened as a result of having the ACA in place. And many of you are familiar with it, but I want to comment on the fact that over 20 million individuals have health insurance coverage, and that the Medicaid program has been very successful in expanding to reaching over 11 million individuals who did not have coverage. The online marketplaces that sell government subsidized private health insurance has also enabled over 10 million individuals to get health care access. And there are 6 million young adults up to age 26 who have received access to this care. The rate for healthcare costs has been decreasing, even though publicly people don't perceive that, and that the level of uninsurance fell to about 9%. That still represents about 30 million individuals living in our country, but it has gone down over a relatively short period of time. And in states that opted for the Medicaid expansion, we have seen that there are more patient visits that get more access to mental health, behavioral health, and that there have been economic gains, including jobs and including budget savings and revenue savings when states have expanded it. There was a concern that if you expanded Medicaid coverage, that all of a sudden people would be in the red. And in reality, it has really achieved a positive economic impact, increasing employment, increasing revenue for hospitals, physicians, and other providers, decreases in millions of dollars of uncompensated care, and savings in terms of other state programs such as behavioral health or corrections when issues were dealt with in the healthcare system. So just to finish my few remarks, opening remarks, we have heard that President-elect Trump is very interested in this maintaining the program of up to age 26, and also no denying of services for people with preconditions. And if that is held to occur over the next years, it would be welcome news because Kaiser Family Foundation has estimated that there would be about 52 million non-elderly adult Americans, 27% of those under age 65, who have a health condition that would leave them vulnerable and uninsured if this precondition element would not be there. However, we need to recognize that these popular perks of having these kinds of coverage does require sort of unpopular parts, such as the individual mandate that requires people to buy health insurance. So it'll be very important to see what rolls out in the next few years or months, probably months more than years. There's conversations about no longer having Medicaid expansion, a loss of the Medicaid coverage. In California, just to make it very local, California receives about $15 billion to cover the Medicaid, another $5 billion to cover covered California. So you can imagine that if there's major changes, major social engineering, what will happen to all of those Medicaid patients, and what will happen to individuals who are on the verge of being low income, but working populations. And in addition, with the threats to reproductive health services and elimination of preventive healthcare services, there are 138 million individuals who would no longer have access to some of those benefits that have been built in to the DNA. I'm going to stop there. Later, we may get into some of the strategies or some of the proposals that we've been hearing about, including high-risk pools of patients or portability of health insurance across state lines or Medicaid block grants. All of them have pros and cons, and there's been a science about some of these experiments that have taken place in the past. So with that context, it gives me great pleasure now to introduce to you our second speaker, Usha Ranji, who's Associate Director of Women's Health at the Kaiser Family Foundation. She has worked very diligently and over the last 15 years, really addressing the needs of women's health from the perspective of how does health policy influence access? How does it influence the delivery of healthcare? How does it impact? How does national healthcare reform impact women's lives? And also, not just thinking about federal policy, because that's obviously huge, but to be thinking about issues that she has explored in the area of state policy as well as local policy. And more than likely, over the next few years, state and local policy are going to make a very big difference. So I'm really thrilled that Usha's here. And just to assure you, as you're thinking about questions or items, please jot them down, because when we finish our panel with Diana Greene Foster, then we will have an opportunity for dialogue with all of you. Thank you.
Good evening, everyone, and thank you, Claire. Thank you, Miriam, for having me. This is a great time, or I should say optimal time, to be discussing this issue. And like Claire said, I have been with the Kaiser Family Foundation for a long time. For those who don't know, the Kaiser Family Foundation is a nonpartisan health policy analysis group. We have two offices, one on the peninsula in Menlo Park, that's our headquarters, and we also have an office in Washington, D.C. We do policy analysis primarily on domestic healthcare issues, but some global work as well, and have over the years had many great partnerships with folks here at UCSF that we are very have always enjoyed, and continue to do that. And so, you know, you can imagine that given that we do health policy analysis as our focus, everything for the past several years has been Obamacare. And now going forward, we're not totally sure what that is, but it's still, for now at least, it is still Obamacare. I work on our women's health policy team, and we have generally taken the perspective of trying to highlight the importance of national health policy issues for women, and particularly for low-income women, women who are underserved, and focusing on the issues of coverage and access to care. So the past several years have certainly been very exciting and busy. And I'm just going to build a little bit on what Claire said and sort of draw out some of the ACA's real accomplishments and implications for women, and take us, and that requires, like Claire said, sort of taking us back a little bit and looking at what things were like before, and seeing how the ACA addressed some of those issues and how the ACA did not address all of those gaps. So obviously, you know, at the heart of the ACA was the coverage expansion, both through private insurance and through Medicaid. And really, I think there's so much talk about Obamacare insurance and the marketplaces and Covered California, which are hugely important. But the truth is, Medicaid is really the building block of the coverage expansion under the ACA. That's where, you know, if you sort of built it from the ground up, it is in fact Medicaid where nationally 11 million people newly became eligible for Medicaid eligibility as a result of the ACA, but many more also have joined in the last several years. It was obviously the ACA's national policy that was implemented at its state level, and so states have taken different approaches. We have more than 30 states that did expand the program, and here in California, we went full force on it really before any other state in the nation. And so what that means is that many more people are covered by Medicaid, and Medicaid has a very long history as a women's health program. It is the largest financier of births in this country, pays for almost half. In some states, it's upwards of 60% of births in the state. It also has a very long history in terms of family planning. Medicaid, in terms of when it comes to benefits, the federal law has several benefits that states must cover. But for the most part, things are at state option. Well, family planning is one of those few services that all states must cover. Women are not, there's no cost sharing allowed for pregnant women who are on Medicaid, no cost sharing allowed for family planning. And family planning has always had a special status in the program, and that is that the federal government pays more of the costs for family planning services than it does for any other services in the program. So, the federal government pays 90%, and that precedes the ACA. That's just to sort of really, we always try and really highlight that even though it doesn't get talked about that way, Medicaid is very, very important for women's reproductive health and has been for decades now. When it comes to the ACA, like Claire said, we are at the lowest uninsured rate in history here in California. It's less than 10% now. That is true for women. Women really did benefit from the law's insurance reforms. So that is, again, when we talk about pre-existing conditions, which is the one that gets so much attention and is so important, we are really talking about several issues that are very important for women. Pregnancy was routinely, and this is, again, when we come to pre-existing conditions, we're talking about women who were seeking coverage on their own. They did not have an employer plan. Maybe they were not eligible for their employer plan, or maybe they weren't working. But if you tried to buy insurance on your own, it was very routine that pregnancy was a reason to deny insurance or to not renew your individual plan. Having had a C-section, a prior C-section, could have been a reason as be considered a pre-existing condition. Having been a victim of domestic violence, having had a mental health a diagnosis of depression, all of those things were routinely considered pre-existing conditions. In addition to that, we should be clear that if you were seeking coverage in the individual market, for the most part, individual plans didn't cover maternity care. So you could not only be denied coverage for being pregnant, if you became pregnant, that routinely was not covered. And again, just sort of contextually, about half of pregnancies are estimated to be unintended in this country. So all of that, the ACA really set a baseline, prohibiting those practices now, so that if you were seeking coverage in any of the state marketplace plans, that is no longer allowed. Of course, it is predicated on everybody buying insurance, and that spreading the risk pool is an essential part of, we talk about the proverbial three-legged stool, and that is, no pre-existing conditions, but everybody buying into the system, spreading the risk, and that there were subsidies for low-income people. So all of those are in question now. In addition to the huge coverage gains, which I think nobody would deny, that's pretty universally agreed that we are at the lowest uninsured rate that we've had. The program also did a lot, the ACA did a lot around setting a floor on benefits. And this is really, especially at a federal level, was really unusual. There were not, again, prior to the ACA, there were not that many benefits that plans had to cover. Regulation of insurance companies to that degree was not that universal, especially at a national level. There was requirements around allowing women to stay 2 nights after delivery, and also breast reconstruction. But that was really it. But the ACA, set these 10 categories, and we can get into more details, but said that there are 10 categories of, quote, essential health benefits that plans have to cover. And one of those is maternity care. Another is preventive services. And the ACA also required coverage that all plans, again, cover without any cost sharing. And that's really key, preventive services for women. And, that's through a few different committees. Claire, of course, was on the committee that set the women's preventive services, which includes all 18 FDA-approved contraceptive methods for women. That includes IUDs, pills, which are the most commonly used, but IUDs, which were routinely have very high out-of-pocket cost share, out-of-pocket charges. That is no longer allowed. I mean, again, the implementation of that has been a little bit bumpy, but it is the law of the land right now. The contraceptive coverage provision has been, on the one hand, highly controversial. I think we all know it has gone to the Supreme Court 2 times already, in the famous Hobby Lobby case from a few years ago, and then the one that was a little less publicized this past year around religious exemptions and employers who have religious objections to contraception. But again, it is also hugely popular among the public. We do a lot of polling at my office, and about more than 7 in 10 Americans approve of no-cost contraception. And somebody pointed out to me, it's hard to get 70% of the public on board with many things. So that's pretty popular. Contraception has gotten a lot of the attention, but I will say also the preventive services coverage is hugely important for reproductive health in many other ways. Claire alluded to them in terms of pregnancy, prenatal visits, many of the screening tests for pregnant women, gestational diabetes screening are all covered without cost sharing, as well as breastfeeding services. And I think that's one to really keep an eye on. Again, lactation consultation, breastfeeding classes, as well as breast pump rental, which again can be a significant out-of-pocket cost. I mean, that really affects, the pocketbook issues for women, as well as, of course, then the ability to obtain postpartum contraception without cost. I will just add there, we can talk more about this in discussion. So we're talking about the potential of ACA repeal. We can get into that a little bit more. And it's very early. The truth is, I think that there are a lot of people, and I'm sure many of you are here are also following this and would love to hear from you about this. That in terms of what can be repealed and quickly, again, we don't know a lot of details yet. The sort of thought is that if the Senate Republicans move ahead with a, quote, quick reconciliation bill, that it would take away the subsidies to purchase coverage in the private marketplaces. It would take away the Medicaid expansion. The benefits provisions that I just referred to are not directly affected by the reconciliation, but like we said, we always talk about this three-legged stool, and having coverage for all these benefits requiring prohibiting pre-existing conditions are very much dependent on the other two legs, which are the subsidies and everybody buying in. So it's not clear to me how you take those away and still keep the market still running smoothly. We can talk more in discussion, but I'll leave it there, and hopefully that's a baseline to start from.
Thanks so much. So it's been a great honor to introduce to you someone who many of you know, and Diana Greene Foster, who is a full professor in the Department of OBGYN, is a research director for Answer, and is a demographer by training. She has conducted many important analyses related to family planning services, cost-benefit analysis. We'll be discussing with you abortion elements that were not part of the ACA. But I wanted to comment that one thing that has been very positive for me over the last month that has been very depressing has been to see how women are voting with their feet. That is, they're going to family planning services, they're getting 13 months of coverage, they're getting their IUDs, or they're getting other long-term contraceptive methods because of this concern. And I wanted to do a shout out that Diana was instrumental in conducting the research, showing that 13 months is cost effective. And I think that that is a very influential policy. Amen.
Thanks. Thanks for having me. I'm going to focus my comments on what will happen with abortion access in the next 4 years, and I'm going to start with the really bad news so that you can think I'm ending on an up note. So the really bad news is that the new administration will clearly harm organizations that provide abortion services. So the global gag rule will probably be reinstated day one, which says that USAID and other international funding can't fund any organization that provides abortion, and those organizations that get U.S. federal government funding can't even counsel women that abortion is an option. So it's like a Democrat-Republican thing. As soon as the first day in office, you either instate that or reject it. So I anticipate that will happen almost immediately because it's so easy. The president just does it, and it's the other organization is UNFPA will lose U.S. funding, and Planned Parenthood will probably, I don't know, I was hoping there'll be lots of lawyers in the audience to say how legal it would be, but there's definitely going to be an attempt to make Planned Parenthood not able to get reimbursement for services that are unrelated to abortion from the federal government. Right now, the federal government, through Hyde Amendment, says no federal dollars can be spent except in extremely rare circumstances to pay for abortion care. And so Planned Parenthood already is not getting funding to do abortions, but it gets money for a lot of other services, and it is a political aim is to make sure they can't even get funding for that, and I don't know how legal that would be. And then the other thing, bad news for providers, is that the next Attorney General has a big role in trying to protect abortion providers from anti-abortion violence, and it's extremely unlikely that this Attorney General is going to do the things that have been done by past Attorney Generals to ensure safety. So that's the super scary news. The most important news for the big question is what happens with Roe, and some people think, oh, day one, Roe is done, and Roe is the 1973 law that legalized abortion, and Justice Scalia died, and that left us with, I should have done this ahead of time. It left, when Scalia was in office, they did not have enough votes to rescind, to pull Roe. And so even if Trump replaces Scalia with someone equally anti-abortion rights, they still won't have enough votes to overturn Roe. And so what would need to happen for Roe to be overturned by the Supreme Court is another justice would have to die. It would have to be one of the liberal justices, and then the Trump would have to appoint another one, and then a case would have to be brought to the Supreme Court that would challenge Roe, and that Supreme Court would have to agree to hear that case, and then it would have to be heard, and then the justices that are there, even some of them who are currently not pro-abortion rights, would have to overlook settled law from the past 40 years to overturn it. And so I think all of those happening in the next 4 years is possible, but it's definitely not imminent at all. There was a cute meme about, I'm making all my organs available to Ruth Bader Ginsburg in case she needs any of them. So you can sign up for that list. And if Roe fell, it would, I think there was a statement, and I didn't go look up the exact wording or put on a Trump accent so I could do it right, but something like, if, we're going to stop Roe, and if you want an abortion, you just go to another state, that as if Roe is just about states' rights, and we'll return to a place where each state gets to set their own moral code about abortion, and people will just travel. And that's not all that Roe does. If Roe failed, if it went away, it would be much more worrisome than that. One thing is that even if that was the only thing that happened, and some states have on their books, if Roe goes, instantly in this state, abortion will be illegal. So some are like ready for that day, which won't come for a long time, but they won't have any lag at least. Well, even if that happens, it's not the case that everyone will just travel. We've said too long, people who are interested in abortion rights, if you make it illegal, women have abortions anyway, and they just have them unsafely. And I think that statement probably has never been true, because women don't all find abortions elsewhere. There will be many women who will carry unwanted pregnancies to term. And so I think we were a little so insistent on saying, giving legal abortion doesn't increase the abortion rate. They have them anyway. They just have them unsafely. So public health, you should make abortion legal, because it doesn't change the number. It just changes the safety. I don't think that was accurate. It was a political message. It wasn't too based in evidence. It was based in this idea that abortion rates are roughly the same in places where it's legal and illegal. which doesn't tell you anything about abortion demand in places where it's illegal or legal. And we certainly know that lots of people, when it's illegal, don't get the abortions they want or feel that they need. So I think that like, oh, they'll just travel is not accurate. But the other thing is that if Roe went away, it would open the door to things that are currently unconstitutional under Roe, like a 20-week ban. So right now, Roe says if at viability, the state can ban abortion as long as there's a health exception. And so if Roe went, then there could be a nationwide law of the land 20-week ban, because all of a sudden it would be legal. There could be all sorts of personhood things that would have lots of ramifications, including earlier gestation. Whoa. And so I think Roe is not imminently going to fall, but if it did, this could be extremely scary. And because I said I'd try and end on good news, at the latest Supreme Court ruling on abortion was Whole Women's Health versus Hellerstedt. And what happened since 2011 is there's been a huge onslaught at state level abortion restrictions, things that regulate facilities or transfer agreements or I can't even come up with the list, but really a huge list, hundreds of different restrictions. And Texas put in an admitting privileges restriction and a surgical center facility requirement, and it placed it, and then it took it away, and then it placed it again. And in response, abortion clinics, were open, then they shut, and then they opened again. And so it was like so clear what was happening, and that these rules had a direct effect on access to abortion. And there was never, even though there was a stated sense that these restrictions were there to improve the safety of abortion, there was never any evidence that that was the case. They sounded like they might, but never any evidence. And so in this last case, Whole Women's Health, which is still a provider in Texas versus Hellerstedt, the Supreme Court said, no, you can't do this. You can't just pass restrictions that place a burden on women. That both the admitting privileges and the surgical center requirements in Texas place a substantial burden in the path of women seeking abortion, constitute an undue burden on abortion access, and violate the Constitution. And then the most exciting bit from me is scientific research on the effect of restrictions, and not just lawmakers' stated purpose, must be taken into account. And to the extent that next Supreme Court case on abortion will have this as its most recent case, there hopefully will be a lot of attention paid to the scientific data on the effect of all sorts of restrictions. And so we at UCSF and others across the country have been doing a lot of work to say what is the effect of abortion access on women's health, on their well-being, on their children. And I think that if it does get down to a question of scientific evidence, that there's now newly kind of a nice body of evidence that says that if you restrict access to abortion, there'll be an increase in poverty, a decrease in children's well-being, a decrease in women's physical health, and a decrease in women's ability to take care of children. And so I certainly don't hope that a Supreme Court case comes in the next 4 years. But if it does, at least we have a lot more evidence, and there can be speaking some science to power, and try and have a rational approach to talking about abortion rights.
Thank you. So I want to thank our panelists for being so good and being on a New Year's diet of information. But definitely we want to have the opportunity now to hear comments, or questions, thoughts, and we will be passing around a microphone so that because we are taping today's session and make this tape available to you all. So Miriam, there's someone in the back, and while you're walking up there, there's several other mics that are coming. I wanted to ask my first question having to do with what do you think is going to happen with insurance companies? One of the things we've done at UCSF is demonstrate the cost effectiveness of contraceptive access. So do you feel that insurance companies are going to renege on the cost effectiveness of the service as they think about it, and then we'll have the first question in the back.
Well, I'm glad you brought it up. So, because costs are an issue that we could talk about a lot, and that we haven't gotten to yet. I think just one thing I didn't get to say is so the contraceptive coverage provision, again, requiring all plans, including self-insured plans, which is a really important part of this, to cover all methods of contraception without cost sharing, has had a huge effect in a very short time. The provision only went into effect in 2012. Well, the data that's come out from a few different groups that have been researching it have shown that the share of women who have to pay anything out of pocket has plummeted. I mean, if you look at some of the data that came out from my colleagues, less than 5% of women in employer-based plans are now paying anything out of pocket for cost sharing. And that's dropped from, over 20% in just a couple of years. So, my work in policy, you don't see effects like that so quickly very often. So that's really, speaks to how important the policy is and how widespread contraception is. We know that more than 90% of women use contraceptives at some point in their lives. This really touches all of us. When it comes to what will happen with it, so the way the policy is, the way that it's written into the law, like I said, is part of, it came out of the requirement for coverage for preventive services. The contraception is part of the Women's Preventive Services Committee that Claire served on. That is, and we can get really detailed, and I'll try not to go down too much of a rabbit hole, but the truth is that is administered by one of the federal offices within the Health and Human Services Department. So it was enacted through federal regulation. It also means that it can be taken away through federal regulation under new administration and new staff. What we have heard is, and like I also said, that the provision did go to the Supreme Court now twice, which is pretty incredible when you think about it. Coverage for contraceptives has gone to the Supreme Court twice in the past few years because of some employers saying that requiring their health plan to cover contraceptives violates their religious beliefs. What we are hearing is that President-elect Trump and Vice President-elect Pence are, at least in their campaign statements, which were pretty broad, that they are very concerned about religious freedom. And so we do think that there could be attempts to expand. There already are religious exemptions put into this policy. Any house of worship does not have to include contraceptive coverage in their plan. Nonprofit organizations that have a religious affiliation also don't have to pay for it, but their plans do have to cover it. They're separated from paying for it. That has not been enough for some groups. So anyway, given the president-elect's statements around concerns for religious freedom, I do think we could see an expansion of that exemption, and so that more employers could be exempt from the requirement. So I think we could see it at the employer level. For plans, I think the plans have been sort of very quiet. On the one hand, we know that higher use of more effective methods of contraception, such as IUDs, prevents pregnancy, which can be more costly for plans. That being said, if they were to open it up on the insurance company side, I'm not sure. Insurers don't like mandated benefits. I'm not sure that they would continue to cover, not that they wouldn't cover, but cover without cost-sharing IUDs. I think that's a question mark.
And one other element, and we'll go to the first question in the back, that I understand is that there may be, instead of having 18 different methods of contraception, if all the FDA approved, that it may be that insurers may select certain kinds of contraceptive methods so that as women seek plans, they may want to be sure that the method of contraception that they want to use is there available.
Yeah.
So would you like to introduce yourself in the back? And
Looking forward to 2018 and 20, do do you think it would be really good strategy for us to evaluate the state legislature situation, the governors, and the federal elected positions to see who is vulnerable so that we can actually vote in people who are going to be supporting what we're wanting to support? Basically, to do that analysis of every single seat. I'm talking strategically right now. Every single seat to see who is conservative, who is liberal, who's on the fence, and to maybe possibly make that a national strategy to overturn what's going on right now. Thank you.
I'll take a crack at it. I'm not a political scientist. I sometimes like to be an armchair one, so I'll take a stab at it. I think, I absolutely think that state politics and state, the ACA is a perfect example. It is a national law that was implemented in every state a little bit differently, and you can see that and that is a long history. If you look at the Medicaid program, is very different, can be very different between states. So I absolutely think that states are going to play continue to play, they already do, a very important role. There are groups that do some of what you're doing, and so I would say you'd probably want to start with groups like the NCSL, which is the National Conference of State Legislators. They are a group that does training for state legislators, and I sometimes think that we don't pay enough attention to our state legislators. Again, here in California, we have term limits. They turn over very quickly. I think they are a group that absolutely needs ongoing education from folks like you because they turn so quickly, their staffs turn over so quickly, and they are often, kind of thrown into the fire. The National Academy for State Health Policy is a group that does this, specifically focusing on health policy. And there is also a National Governors Association, which tends to focus less on the legislators, but still is related. But I absolutely think they will continue to play a role. I mean, if you even look at the rollout here in California of Covered California, I mean, designing that program, designing the California Health Benefit Exchange, while there is a private group that's part of that, they absolutely had to work with the state legislators. And I'll just make another plug, another state level position that I think in terms of this insurance issues that doesn't get enough attention are insurance commissioners. Here in California, we have Dave Jones. We have a very sort of progressive, active state insurance commissioner. They vary a lot between states. It's not my area of focus, but they are sort of a quiet office that has played a very large role in the past 5 years. I think there's sometimes when we talk about costs, I mean, that's just a really broad word. There are healthcare costs, the system costs, and then there are the costs that individuals face. And typically the public, and we see this a lot in our polling, the public is very concerned with their out-of-pocket issues. And one of the big factors there is prescription drugs. And so we point to contraceptives that, many women no longer pay anything out of pocket for contraceptives. That's obviously not the case for other drugs. And so that tends, when we do polling on sort of what are your top concerns, out of pocket costs for drugs tends to be very high on the list. But I think that sometimes gets muddled with larger health system costs, which are, again, premiums are always going up, but the truth is they've been going up at a lower rate these past few years than they were before.
So I think this question brings up several issues. One has to do with just information and how this is very complex. I mean, even experts on health insurance or health coverage can tell you that it's difficult to navigate. So I think we need to acknowledge that the power of language, or how do we start using the concept of social math, which is how do you break down something that is a broad, big issue into perhaps smaller things that are more manageable that people can really understand. And to me, we have not done a very good job in this country explaining all the perverse incentives that we have in our healthcare system right now. It is not a value-driven healthcare system. There's still too many incentives in insurance companies and in the healthcare system to keep our hospital beds filled, for example, or to order the extra tests, because the incentives are order it and we will reimburse you. But there is now a very major shift in our country to recognize that we cannot maintain the trillions of dollars that go into our healthcare dollars without the kinds of outcomes that we want to have demonstrated impact of doing better quality care at a reduced cost. So people are really moving into having bundled payments. So for example, a pregnancy or an operation or ortho, we're beginning to move because of Republican concern about this issue. It's called MACRA, that there's a real concern about being able to demonstrate outcomes as it relates to a certain base of money, of funding and reimbursement. So it's like taking a huge ocean liner and moving it from one kind of direction to a whole other and getting, I think the third point I just want to raise is we have to engage consumers in all of this dialogue and in conversations and having them understand why when they have done 5 hours of studies on the internet and come prepared to the doctor saying, I demand that I have this kind of test or this x-ray or this MRI, how important it is for them to gain knowledge from the provider. And of course, the provider is not getting reimbursed, especially under Medicaid. Reimbursement is very, very low. We can't cut Medicaid reimbursement lower than it is today, as far as I'm concerned. But how do we educate the consumer about the fact that more testing, for example, in breast cancer, more testing can be more dangerous for you than under testing? So it's a combination of several huge factors that are going on in the climate. And my concern is that the kind of simplistic thinking and reasoning that we're hearing, when the first comment was, show me a woman that really needs contraceptive, that can't pay for contraceptives, right? That
From the
new Secretary of Health,
Yes.
whose last name is Price, which I think is a very, very interesting word. But I'm just saying that I think that we have to find a way to communicate, and I think bringing people together to communicate is very important, but understand that it is complex. There.
So I actually had a question I wanted to jump in and ask, and I was thinking about it when you were talking about, the evidence is here and there. I think you were talking about it in the context of the Supreme Court. But in general, all of us who are so busy generating evidence, in the face of now an administration that's coming, that I don't think evidence helps with. So it really, so I think we need to think about that too. Like, what is it that we can generate? Part of it is probably this translation to the public, so being more, figuring out how to make it simple and so people hear sound bites that they can resonate with that are in fact evidence-based. But I just wonder what your thoughts are on that, because I just don't feel like going with the evidence all around is necessarily going to be that fruitful.
Yeah, I was definitely thinking of the Supreme Court and not the office of the president.
No, I got that, but it just reminded me because it was actually just one reassuring thing I'd say.
Yeah, no, I think that evidence certainly it's important for public opinion, and in some ways we've been so focused in abortion on the question of fetal rights that we haven't even looked at what, we can state it as a right that women ought to have this right, but there wasn't the kind of evidence about what the harms were if she didn't have this right, and it shifts a little the conversation. And so it's about public opinion, and it's about knowing what questions to ask. If you're going to cut contraceptive if you're going to restrict people to pre-approved contraceptives, what are you going to do about the people who become pregnant because those don't work? What about those costs? And so it's figuring out sort of what the questions are to ask and understanding the big picture of the importance of access to a whole bunch of reproductive health services.
You've spoken very clearly, and I think as we would all here expect, about access to contraception, family planning, and abortion, and how those come up. And as the political system cycles, we always go back to the same abortion and family planning issues. And I'm just curious whether any of you know, in terms of reframing the argument or bringing in other things that maybe don't have that history of liberal conservative baggage or history, and looking at something like maternal mortality, which in this country has, unlike most of the rest of the world, been increasing at an extraordinary and shameful rate, whether anyone has looked at what's happened with maternal mortality with ACA and can frame it, I don't think left, right, anyone would say, that that's not a shameful, how can you defend not protecting that?
Well, I think you're right that we do have to think more broadly. And I will just say, I've been working on Medicaid issues for quite some time, and we haven't talked a lot about, expansions of Medicaid. Pre-ACA for decades, Medicaid covers many, many pregnant women. Part of the reason of that is because back in the 70s and 80s, there were very high rates of infant mortality and a lot of concern around, as particularly in states in the South. And so part of the response to that was to expand eligibility for pregnant women for Medicaid. So and that feels like a long time ago, but it is absolutely the outcomes of that we still see today. Covers, half of all births in this country. So I think that there are opportunities for that. I think we also have to maybe, getting back to the issue of, sort of the research, the issue of maternal mortality has absolutely gotten attention. I think some of that story, though, if you look at the studies that came out last year, the rate here in California actually has gone down quite sharply. And you see the differences between, and that I think didn't get enough reporting, the differences between California and all the other states that were in that study. And so I think asking the questions of why, what's different there? And again, in California, we've had very generous eligibility for Medicaid for low-income women. So I would say, let's look at that.
But also, let's not seed contraception. Let's not add contraception to the list that's necessarily so partisan. It is only recent that Republicans weren't for contraception. So we don't have to accept that as a new reality. That could have been a temporary blip of insanity, and we'll return to more reasonable times when the Bushes were on the Planned Parenthood board, for example.
Well,
And Nixon started what?
No, it was the first President Bush who started Title X funding.
see.
He signed the legislation, but
I'm willing to grant you abortions, partisan.
But I am concerned about how many of the contraceptive methods are even being defined as creating abortions.
Yes.
So I want to go back to Slido because there's a question here. It relates to preterm birth, and we are the preterm birth initiative. So the question reads, to what extent is the population marginalized for reproductive health care, the same population as, marginalized for reproductive health care access, the same population having preterm birth, and how can we model the quantity?
I mean, my sense is that we're talking about low-income, marginalized women often who have so many other things going on in their lives that they may not be thinking about their own healthcare needs. There's too many other stresses in their lives. They may not have enough housing security, safety in their communities, unemployment, et cetera, poverty. I would say that there would be a very high overlap. But I think that we have not taken enough or we need to recommit ourselves to the preconceptual education and the helping women to be as healthy as possible. I think the message about how do we assure that your diabetes is under control, and this is obviously something that Larry and others here have thought about a lot, is we as a country do not do a lot of good planning. Years ago, around contraceptives, there was a report by the Guttmacher Institute that also does a lot of state-by-state analysis. And that report showed that over half of all the pregnancies are unplanned in this country, and that people are not using contraceptive care. And I was called by that wonderful newspaper, USA Today, and asked to comment on it. And at the time, Lady Gaga was very popular. And I said, in this country, we do more planning for how we're going to get 2 tickets to see Lady Gaga than planning how many children and when in our lives we're going to have them. So I feel that as a country, we have not given enough support, nurturing around planning, one of the most important elements. And that to me is if you're obese, or if you have blood pressure that's out of whack, or if you have depression or undernutrition or many, many other factors that we know stress out of control. If we all talked about how we want the best for women, that might change some of the conversation. But I worry a lot about the attitudes about women that have been demonstrated in the election thus far, and whether many of these attacks on Planned Parenthood really are about attacks on women. Yes, sorry. Introduce yourself, Jenny.
There's so many things to say about this, but I think.
Do you want to introduce yourself?
I'm Jenny Brindis. I'm from urology and surgery, but I've had a previous life in adult reproductive health care and women's reproductive care. But I teach graduate students now in health policy, and I actually have them go to the exchange and try to buy health insurance through Covered California, and I give them scenarios where they're going to end up being Medi-Cal eligible versus their middle-class family in San Francisco. And it's just really enlightening that even people at a graduate level don't even know how to buy health insurance. And these will be the future health nurse practitioners and case managers of the future. So I think there's a really new definition of health literacy, and health literacy is actually what is health and how do you access care and how do you buy insurance, and none of that is covered in any of the educational programs that most adolescents, if they terminated high school, how do they even know how to do these things? So I think it's really a challenge for us. I also think the reproductive issue is, it's more polarized. It's not just cost effectiveness. If you've got the rational Republican who understands cost, that argument will work. But if they're really fundamentalists, then that won't work at all. So, not everybody's a Pete Wilson, basically. Yep. And we kind of forget that. So I think it's really important to keep that in mind. And I think the last thing is the state of Texas is the best example. With all the turbulence, they actually have seen the highest spikes in maternal mortality. And when you look at, it was really the New York Times that covered, like, when they had those potential restrictive laws, that people were Googling, how do you do a self-abortion, right? But not everybody reads the New York Times. So how does that message get out there? And I think really thinking strategically about how to have a messaging campaign that really fits a lot of different demographic categories that people can relate to the information.
I wanted to make a comment that when the ACA was established, there were actually millions and millions of dollars that were built into it for outreach workers in the community, enrollment workers. So part of the reason why there was success reaching the 20 million plus, minus, et cetera, that happened not because we were expecting or we were waiting for people to go to the computer and sign up. I think that there was an acknowledgement that there are a lot of people who don't think about insurance and that they needed promotoras and then they needed individuals from the community to help guide them. We've had a number of challenges in our state and across the country with some of those computer systems in the past, and some of those glitches have been eliminated. But I think that was a very important ingredient. So whatever the repeal and replace elements are going to be in the future, if there isn't going to be sort of a community sector kind of outreach enrollment, that will also fail. And you're right, Jenny, about just thinking about various segments of the population. And I think we need to bring Republican daughters to the table, or fundamentalist daughters. I once met with a board of directors of a foundation, and they were all established white elderly gentlemen. And I was talking about teenage pregnancy, and I know that I wasn't getting traction with its board. And all of a sudden I said something else, and I said, how many of you want to be grandfathers? And I talked about chlamydia and STIs, and you could have subclinical cases of STIs, so that when your precious daughter or son has a wife and they're trying to get pregnant and they may have an infertility problem. So my whole conversation changed to, how do we protect the fertility of our young people so that when they're ready to be parents, they're able to have them? And it just changed the whole conversation. So I think we need to do more of that kind of like reshifting, rethinking, and also like thinking about how much data do you really need to share, because so much of this is emotional.
Jonathan Hughes from the San Francisco Department of Public Health and PTBI. This question's for you. You mentioned Medicaid block grants and the possibility of what the scenarios can be. And I think the conversation conversations, it's important that we've been focusing on Medicaid, given the portion of births that are covered or funded through Medicaid. So if we were to change the model, and I know there's been a lot of discussion about block grants, what would that mean for California? What would that mean for the country in terms of
Well, that's a really, really important question, and I think that one of the concerns we have is that up to now, for, you know, if a state has an influx of poor women, that there was access to increasing the numbers of women that would be served. Under a block grant, you get a set amount of money that is being established, and that one of the challenges is that that block grant is, that rate for the block grant is tied to inflation, rather than what the numbers are, what the demands are in that particular state. Let's say that you've had an influx or there's been a bad unemployment, you would still get the same dollars. So what will happen in our own state is not clear to me, because of the fact that, you know, we could only, if we're getting $15 billion, we're not going to be able to make that up.
Hi, my name is Bobby. I'm a medical student working with Dr. Cooperman. My question was more about what efforts are ongoing right now for doctors groups to organize to issue a united message to Congress, whether it be independent or through like ACOG. I know from the students level, there's a lot of organizing happening right now to talk to Congress. I just wanted to know what role there is. I think in the public perception, for better or for worse, doctors have a level of authority when it comes to issuing statements about like patient safety and advocacy. So how are we exploring that? And in December, a group of students from UCSF and a couple of the East Coast schools organized a campaign called Protect Our Patients, and in a matter of weeks we collected over 4,500 signatures from health professional students at every single state at 150 different institutions. And on Monday we were in Washington DC, we had an action, and then we proceeded to hand deliver the petitions to all 100 senators. And we had over 20 one-on-one meetings with senators and health legislative aides. And then at the end of the day, we had a Facebook Live event at Senate Minority Leader Chuck Schumer's office with a couple of other Democratic senators, really talking about patient stories and what it would mean to repeal the ACA. And I had the opportunity to talk about women's health in that. So that's kind of some of the things that we're doing as students. But again, I think that the power that comes with having that MD next to your name is a lot. So just wanted to know what's happening on that level.
I would say it's a work in progress. You know, many providers are very deeply concerned, as you are and your peers, about what's going to happen. I mean, when the unraveling of the system, we don't have enough information, but definitely ACOG, American Academy of Pediatrics, American Academy of Family Practitioners, in terms of nurse practitioners, family medicine, and you know, because we don't really fully know what's going to come down the pipe, I think people can do anticipatory planning, but right now I think there's just too much of a blur. And my worry is that there's going to be so much thrown at all of these different professional groups that deciding what the priority topics are going to be, where we're going to come together as a federation of providers, or hospitals are very concerned. I've known a number of hospitals that have stopped doing any kind of planning for building capital improvements because they're so worried about uncompensated care that they were in the past, you know, loaded with. So through the ACA, some of that has been removed, and they were able to do better hospitals, et cetera, better systems. So I think that there's a lot of large groups that are very dependent on what the healthcare system gives them. And so my sense is that as we hear more, we will be mobilizing more. Do you have any other?
I would just say I really applaud your efforts. I was at a rally over at San Francisco General last weekend where Congresswoman Pelosi and Congresswoman Spear and Congresswoman Lee were all there and leading it. And this question came up of sort of what can we do in this time? And they all very strongly reiterated the need for patient stories, hearing from patients and their providers directly. That is, yes, we need some data and we need some research, but we absolutely, the part that really gets through is hearing from people directly about what this would mean for them.
There was a clip on NPR around the state of Indiana, and their Secretary of Health, who's now going to be the head of CMS, Seema Verma, had negotiated with the federal government to have co-payment for Medicaid. So even if you were a patient at poverty level, you would have to pay $1 to get access to care. And then they panned to a patient who had paid her $1, had a receipt for the $1, and somehow the $1 receipt got lost in the system, and so she could not access some of the drugs that she needed. And then they interviewed the state of Arkansas, where Joe Thompson, who Secretary of Health there several years ago, said, we tried that same experiment in Arkansas, but it would cost us so much money to keep track of those dollar bills that we gave up on that system. So I think that collective collection of sentinel stories like that, where some of these experiments have actually been implemented in states before and they didn't work, we need to bring some of that history to light.
Another comment. I was directing the Foreign Aid Agency's population program when Ronald Reagan came in, and he appointed right-to-lifers who had no particular experience in healthcare or foreign aid in various places to keep an eye on us and create policy. And I would say that the evidence will be helpful within agencies in terms of fighting back. But I'm very worried because if you still have money, and we had a Democratic Congress during a lot of the Reagan years, you can work around a bad policy. We get a combination of really bad policy and no money, I think we're in big trouble. And I noticed Tillerson did not say that he would support global reproductive health when asked in his confirmation here.
I think that it's been refreshing. While we get the next question, I think it has been very positive. The calls that I see from a variety of newspapers, a variety of sources, asking for a public dialogue about the repeal and replace, and what are we repealing with. And I think a very important question will be, will this replacement actually reduce healthcare costs? What will be the impact? How will they achieve those costs? I mean, I think we need that kind of accountability building.
This may be controversial, but I've been trying on this idea. This has to do with language and messaging about reappropriating the idea of family health, actually. If I think of anything our new president-elect seems to trust, it's his family. And so there's so much evidence about how the state of a family's health is related to the woman and the mother's health. So I'm just wondering if there's any thought or reaction about language around the family's health, because I'm thinking about this globally as well, because it seems to have been appropriated often by the right, and because we know the lightning rod that comes with women's health, women's rights, reproduction, just how to modulate the conversation. So
Take any advice.
I think
Sounds worth trying.
I'm torn, and honestly, I think probably a lot of people are. It does feel like it does certainly appeal to a certain group, perhaps especially our new vice president to be and his group. It does also feel like it leaves out a lot of women as well. So I think probably we need a multi-pronged strategy, and it's not that shouldn't be part of the dialogue, but it probably can't be all of it. Mm-hmm.
Just to add, I have to say, and I know it is controversial, and I think the multi-pronged comment is probably right on, because I found, and I think many of us working in PTBI have found, you can go out there and it can be really difficult to get traction talking about prematurity with just a general audience. And it's amazing how that changes when you start talking about healthy babies. And everybody can come around the table when we're talking about healthy babies. At the end of the day, it's still the same stuff that has to be addressed to reduce prematurity or, improve the outcomes as you'd be talking about for healthy babies. So maybe there is a role for mixed messaging that works hard to we end up getting the benefits for women's health that we need, especially when we're talking about reproductive health for healthy babies. But of course that becomes very problematic when we're talking about family planning. Although it still ends up, right, you need family planning for healthy babies.
And I think that some of that conversation is happening in another side of, we've absolutely seen a lot of campaigns around long-acting reversible contraceptives and the effectiveness and the uptake in that, and we do see an uptake in that. We also see that there is a lot of concern about coercion, and that that maybe really we should be talking about the most effective method and the best method for you as an individual woman. And so that while there are certainly reasons to elevate the dialogue around IUDs, that it is not necessarily what everybody is seeking. And so in the family planning world, I think is really after sort of several years of really trying to, again, raise the visibility around LARCs, but is also is grappling with, well, how do we make this so that it is really, again, getting back to a choice for women.
There's a question up here from Ife who spoke at the last series. We had a 2-part series on breastfeeding, and I know breastfeeding was brought up. And she knows that she completely agrees with Monica's comments, and she wonders if there are any plans to partner with breastfeeding organizations or programs focused on achieving breastfeeding equity.
I don't know of specific strategies. I mean, I will just say that, again, I think that this issue also comes up. We have the ACA included this coverage for breastfeeding, but we're talking about coverage there. But what women actually choose to do, postpartum, that is, the coverage is just one part of the story. That doesn't mean that everybody needs to be subscribing to the same philosophy and the same methods.
Okay, I saw another one here that's been here for a while, and someone mentioned the senior Bush in Title X. The question was raised early on, which is, what do you anticipate might happen if Title X is gutted?
So there's a lot of talk of Title X, again, is the National Family Planning Program run out of HHS. Over the years, Medicaid has become the primary public payer of family planning services. That being said, Title X is still really important. It's run as a grant program, so every state gets an allotment of dollars, and some of those dollars go to Planned Parenthoods. And again, purely for family planning services. They are isolated from abortion services, but they are for family planning services. There have been multiple attempts to gut Title X. The last couple of House budget proposals have basically put $0 for the program. I think that the direction that the Trump administration and many other Republicans have talked about over the past few years is redirecting Title X dollars so that they go to community health centers. So i.e. that they cannot go to, and the language is there in the reconciliation draft from last year. Again, we don't know if they're gonna follow that, but let's take that as our model, that they would, the draft says that all federal dollars, including Title X, cannot go to any provider that provides abortion services, even though the services, the dollars are for family planning, and that the dollars would be, and that created an uproar a couple of years ago. And so the Republican answer to that was to redirect the dollars to community health centers. I have not heard any different strategy than that. I don't know if others in the room have, but I imagine, and this is, again, another thing that's going on I see in the family planning world is the Association of Community Health Centers has been relatively quiet, and there's a lot of concern about if you take away dollars from family planning clinics that have expertise in providing family planning counseling and services and direct them to community health centers, do they actually have the capacity to serve the millions of patients?
Linda has a question.
Thank you. So This panel has been incredibly informative about the ways in which things could get deconstructed and, what some of the strategies so that we're having really from a place of knowledge or at least, tactics. But one thing I haven't heard, one other worry is something that to me seems quite new, and I, would be really interested in your thoughts on this, that how the president-elect could select, and particularly with the question of the what will insurance companies do, or what will some of these groups do, when the president-elect, can target an individual company or organization and say, like with the cars, exporting industry to another country, or something specific, and then their stock goes down, or they receive a lot of bad press. I mean, I think, or even the press itself may pull back from those kind of controversies. I could see that happening really clearly here. So if one of the big insurance companies decides to buck the trend that in the congressional repeals, or what's happening in Medicaid, or what might happen in Medicaid, that they could get called out and named and shamed, by the president himself, or other high-profile individuals. How would we even possibly counter that, or what are some of the thoughts on that?
I've had a lot of sleepless nights, Linda. I had never thought about that. I thought more when I was asking the question originally about whether coverage will remain because of its competitive edge. I mean, I see insurance companies are going to be competing with each other to retain the women that have been enrolling in these programs, and I had not thought about the potential for the other. But I do think that what Usha said about the 70%, I mean, most people in America support women's access to family planning, and particularly low-income women. So this intersects, I think, the maternal and child and reproductive health worlds, which is, if people were objecting to abortions, because of moral reasons, and then did something about those babies that are born and cared for them, I have much greater acceptance. And I think that women are the political football here. And so that does concern me a great deal. And I'm speaking as a person here, not as someone representing an institution. So I would think that if the new president finds that demographically we're going to have huge influxes in pregnancies, I'm not sure what they're going to do about caring for these babies.
I will say I have AHIP, the Health Insurance Association, again, is another group that I think is being very careful and in sort of been relatively quiet, which has surprised me, but I guess they need to wait to see. But, I am concerned about what you're saying. I also do think, though, that the repeal and replace crowd also needs the insurance companies. And so maybe that's, that's the sort of balancing side to that, because they are claiming that they are going to replace it with something bigger and better. And so whatever form that takes, they also do need at least some of the insurance companies to come along.
Yeah, I just wanted to respond to Linda. I also did want to say that another group that has been relatively silent, but that's because they've been doing a lot of work trying to figure out what their strategy is going to be, is the philanthropic community. I was on a call this morning with Robert Wood Johnson as a breakthrough leader in nursing with Robert Wood Johnson, and the American Nurses Association has been responsible for some of the pushing of the no repeal without replacement language. And there have been at least 3 conversations that I know about in the philanthropic world to really think about what their strategy will be in the context of whatever insurers will and will not do. So I think that's another group that we should be thinking about, not only hearing from, but also partnering with as we move forward in this sort of uncharted territory.
Hi, my name is Molly. I'm a social worker at UCSF, and I work in pediatric dialysis and kidney transplant. And I'm curious to know maybe if you have any thoughts on the potential ramifications of cabinet members coming in who are very, very anti-vaccine, and what that might look like for women and children, especially thinking about HPV.
I don't know enough about the stance on vaccines. There was the uproar this week around Robert Kennedy Jr. And again, I don't know what's meant to be a distraction these days and what we should really be terrified about. Again, I'm speaking as an individual. The only thing I will just say that I think that I am concerned about in that realm, and more stuff will come, but I spoke earlier about there is this issue of concern on the new president's administration around religious freedom, and that is in their documents and it's in their language, and I think there is a group within the Republican side there that is really going to push that. And again, I think it's going to start with contraception, but I do have concerns that it could extend over to vaccines, and particularly HPV.
In regards to the HPV vaccine, Margaret Tempera, who's a medical oncologist here, read a really nice editorial a month or two ago in like the JNCCN, which is an oncology journal, talking about HPV vaccine for cancer prevention. So there's kind of a different, here's an adult oncology talking about, and hopefully you would like to have prevented that, right? So this might be another kind of partnership of getting an unlikely group that you would not think of as a medical oncologist to buy into like supporting, this preventive strategy.
Hi, my name is Claire. I'm a student in the Global Health Program. It's just overwhelming hearing about all the complications about the healthcare system, the future, and we're learning that a lot of the healthcare costs do end up going to administrative costs. And I was just wondering, is there even a hint, or even does anyone even whisper a thought of a single-payer healthcare system in the future of the U.S. system?
And I think there have been attempts here in California. The truth is the bill did actually pass here in California twice, I believe, under Governor Schwarzenegger, and was vetoed. But when we were talking earlier about sort of are there any bright lights? I mean, for me, and again, I fully admit this is the what do they call it, the liberal West Coast bubble, but I am inspired. I am optimistic about California, and so I don't know if that means that we're going to get single payer in California, but if if there are movements in that direction, I think we would be the leader.
Okay, well, I want to once again thank our panel.